Respiratory, and here at Center Lakeside, we've been working on trying to get our patients off our ventilators a lot quicker and stuff like that. So I, as a respiratory therapist, kind of want to educate you students, the RNs, as well as to an emphasis on kind of what we do as RTs when it comes in that role. Together, nurses along with physicians and RT, it's crucial to kind of all work together to try to get these people off ventilators. And this is kind of to let you guys know more of what respiratory does, especially those that haven't seen respiratory in action. Sometimes we have ventilators here when you guys come and kind of shadow us, and sometimes you don't. So here's kind of what we do when it comes to that, the role of kind of getting these people off these vents. So some of the three main reasons for the reason why we would put somebody on a mechanical ventilator is one of them is airway protection. Sometimes you get people OD, seizures, various reasons where they can't protect that airway, so we will intubate them to make sure that they are safe. Another big reason is ventilatory failure. And what that is it's basically kind of high CO2. When levels of CO2 get too high, people kind of go into that coma effect, and it makes them real sleepy, and then they get worse, and it's like a spiraling effect. So we will put somebody on a ventilator for that reason. This could be somebody like a COPDer that's having exacerbations or something wrong with their lungs. Hypoventilation syndrome, which happens from just some people just not taking big enough breaths. Sometimes it happens with very obese people that are obstructing and stuff like that. They kind of they get real bad, and then eventually they need a little bit of help on the ventilator for a little bit. And one of the other main reasons that we kind of put people on a ventilator is for the hypoxemic respiratory failure. And we are seeing a lot more of this with people, especially like COVID now. These are people that just need high O2 demand, and the levels of oxygen in their body is too low to where we have to put them on these ventilators to give them things like PEEP and stuff like that that helps with their oxygenation. And with the COVID, a lot of times people have a really bad pneumonia, and when you have a really bad pneumonia, I mean, it just takes time to heal. And also, you also have things like fibrosis that can happen, scarring of the lungs. And when that happens, they're not going to work well. And so those are some of our biggest challenges, especially with COVID. So we've been having a lot more people going on a mechanical vent for just hypoxic respiratory failure. A lot of the reasons that we know that these people are going into failure is something we call an ABG, which is an arterial blood gas. So that's one of our main tools to figure out if this person's failing or not. And so by looking at that, the ABG, we can say, all right, this patient is in ventilator failure, hypoxemic respiratory failure, or maybe both. And so in that case, then that will buy them a ventilator. And so that's why the reasons we put someone on a ventilator. Now, the problem is trying to get them off a ventilator and when's the right time. And so those are, problems in themselves. And so it's not just kind of just one thing, it's a lot of things we got to look for. So when we try to get someone off a ventilator, we need to know, do they qualify for what's called a spontaneous awakening trial, and that's where the sedation was kind of lifted. And then if that's the case, then we can put them into a spontaneous breathing trial, okay? And I'll kind of go over that a little bit later. And the first thing that kind of qualifies them to even be able to go into these modes is we have to see, did we fix the initial problem? And that's the things that we do look for. And so in determining if we can actually even get to that far in our next plan of care. So when it comes to the spontaneous awakening trial failure prior to what we're going to do, the red I kind of have highlighted, so it's more of nursing. So nursing, I mean, along with respiratory, we look for things like, are they hemodynamically stable? Agitation is an issue. We do have a lot of stuff in our scope of our policies and procedure that kind of goes over more things that would fail somebody prior to even them being able to go into the spontaneous awakening trial. So that's more kind of what the RN will do. They're the ones that kind of wake up the patients, and that's just something that RNs get with the RTs, usually in the mornings, and we talk about, hey, is this person ready to even, be awakened, and then can go from there to be put into the spontaneous breathing trial. So when it comes for us, we look for things that will actually qualify them to go into that mode with, is that patient able to protect their airway? Are they on 50% of oxygen or less? Those are some things that we look for. Is their PEEP less than 8? And so with the PEEP, a lot of times we have to go higher PEEP with people that aren't oxygenating well. And so that helps with oxygenation. And if we can't get that down, then obviously, we're kind of failing that person before we can even go to the next level. Vasopressors, that's something that we both kind of look for, RNs and RTs. If that person is taking any type of, Leofed or something like that, that's keeping their blood pressure, up, then that's a sign that maybe they're not quite ready. And so those are things that we absolutely look for. Lack of inspiratory efforts, and some of the other daily assessments we look at with a person that's on a vent is the respiratory therapist will look at your chest x-ray. Do our lungs look better? Do they look worse? Is our tube in the right place? Are they having copious secretions? And what does our ABG results look like? So those are some things we'll take in consideration. If those start to look good, then we can kind of move on to our next step. So,
can I ask a question?
Yes.
How long does it take to get the ABG results back after you?
They're fairly quick, so within minutes, and usually it depends on once we draw the blood, take it over to lab, and it kind of lab just how busy they are. We usually tell them right away.
Really?
It's usually pretty much stats. If you don't get the blood kind of ran pretty quickly, it'll clot, and so we try to get that ran, and we try to let the technicians back there know that we have one, and so it comes out fairly quickly. And so that's good because then we can make changes depending on how that looks. So if the RT says, hey, this looks good on my end, then we go to the RN and we go, hey, I think we're ready, depending on, obviously we'll have a physician order that says, hey, SPT, do the trial for this patient. What the RN has to do, which is has been a little bit more difficult because of, I think the rural area, we have a lot of people on vents with polysubstance abuse and stuff like that, so we've had a little bit harder time getting our patients off sedation, and that is one of the hardest difficulties that we've faced here. And so we look for RAS scores. In a perfect world, I would like a RAS score of 0. This patient's alert, calm, I can talk to them, they're gonna follow directions, and then I can go through my numbers, and then we can go, oh, they look good, are you ready to pull the tube? They shake their head, yes, and we pull it. But that's just something that there's a lot more to that RAS score that, those are things that we're kind of working on together to try to figure out if we can lessen sedation. Is my vent, can I do something on my vent that makes them more comfortable so I don't have to, maybe they don't have to be sedated as much, and those are just all the factors that come into piece when we're trying to get these people off a ventilator. And now, when it comes to, say, the RN, okay, they're on the sedation vacation, and we're ready to go in and do our measurements that we do. When we have our patient, we look for, we will put them in a spontaneous mode. And what that is we let that patient breathe on their own. And we give them a little bit of pressure support. And pressure support is what we give them because they're breathing through a tube. So we want to give them a little bit of support. And then we kind of see how well they do in that. Things that we look for, is their respiratory rate is it below 35? Is it above 8? Those are things that are they awake enough to kind of, even breathe on their own? We look for things like, is their SpO2, is it their sats, are they dropping, or are they staying kind of at the normal kind of range? And if these are kind of normal, we can get through it. Then we look for other things that we can do our numbers when we look for measurements. So we do an RSBI, which is we look for, do they have like a good respiratory rate with a pretty good tidal volume? So that's something that we can test with our ventilators, and we get a number. If that number is less than 105, we have a good chance of that patient being successful when we get them off the ventilator. We also do a NIF, which is a negative inspiratory force, and what that is we want to make sure that that patient has enough strength to actually take a big breath in. And so we look for a number above -20. And so the way I kind of wrote it is how everything would fail, but if you get above -20, then we know, okay, that's a good chance that that person has the good respiratory effort to take some good breaths in. Overall, we look for patient tolerance, how they doing with, agitation, this and that, and sometimes we overlook that. We got to look at things like anxiety, what that person to be calmed down, or the reason they're failing is because their respiratory rate is high just because they're anxious, and those are just all the kind of things that we take into consideration when we're saying, when the RT says, hey, we're trying, they're able to qualify to get off this ventilator. The last thing we look for, if say all of our stuff passes, we look for a cuff leak. And that's very important because sometimes with intubating a patient and the various things happen, traumas happen, if we deflate the cuff and we don't hear any like gurgling or airflow through that, then that means that airway is swollen. And so if that's the case, we can ask the doctor to prescribe something like Decadron or something like that. And then we will proceed to do the SBT the next day, because we want to make sure that when we pull that tube, that airway is open, it's clear, it's good to go. And so those are kind of things that we look for. If we get our numbers that we want, along with vital capacity, which just means that they can take a big enough breath that we think is sustainable for that person, depending on how big they are or whatever, we will say, hey, we're good to go. SBT for the respiratory, we pass. And then that will go down over back to the RN. That's when the RN will kind of go, okay, they'll do all their checks and stuff. Does this patient pass with all my stuff? Mentation-wise is a big thing with the RNs. Once they're off all the sedation, am I going to be able to take care of this patient? Are they going to be able to follow enough directions and rules to kind of do what we need them to do when that patient's off the ventilator? And so if the RN passes that patient, then we go back to the physician in rounds. We tell the physician, hey, respiratory passed this patient, the RN passed this patient, and then if everybody's cool with it, then we extubate the patient. And that's kind of what we do, and that's kind of how we work together to try to get the patient off the ventilator. So with that being said, any questions, concerns? I know I talked kind of fast, but is there anything you have questions on that? Go ahead.
What's the time frame that you guys are looking for that a patient should be on a vent for?
So the time frame, how long we want a patient on a vent for?
Yeah, like what's the least and the most?
I mean, a lot of times if you intubate a patient, say just for drug overdose, and so a lot of times you'll keep them on for at least 24 hours. Other than that, as soon as you can get a patient off the ventilator, the better. And so it just depends on the condition. There's so many other conditions that with COVID, it kind of prolonged a lot of us trying to get these patients off. And so when you got a really bad pneumonia, you got some fibrosis setting in and all that stuff, they were a little bit harder to get off these ventilators, because with something like ventilatory failure with CO2, a lot of times we can dictate that a lot easier, because we can change the respiratory rate. Some people breathe above it, or I can increase their tidal volume. So by doing those two things, I can take CO2 down a lot easier. Whereas when someone's not oxygenating well, that just takes a lot longer, because when you got a bad pneumonia, I can give them a lot of oxygen. We can try to give them PEEP, but that just sometimes it has to reside. If they have a lot of secretions and stuff like that, we got to kind of get that out. And so they take a little bit longer. A couple days would be like just ideal for everybody, but just with the COVIDs especially, it's taken a little bit longer. And some of these, like I said earlier, with the polysubstance abuse and stuff like that, a lot of patients give them all the sedation because they need it, because a lot of them, they're just so used to all this stuff in the system, so we're having to give a little bit more. So when you back off of it, then it just they kind of have a lot more anxiety issues and kind of thrash around, agitation. And so those are things that when it comes to nursing is just you know, that's just, it's tough. And so those are things that like we've all kind of as a team been working together to where it's like as my role as an RT, I can go, can I put this patient on a more comfortable setting so where that patient doesn't need as much sedation. And so those are just kind of all things that we've all been trying to work on so we can hopefully get this, you know, the patients off sooner than later.
Thank you.
So yeah, any other questions?
Thank you very
Good?
much.
All right.